Okay, well, it's my pleasure. I'm David Thompson, the Regional Coordinator for Africa for the Tribute to Life project. And I'd like to welcome you all to the 17th webinar for the project. Today's topic has speakers from Canada, Australia, and the UK to share their insights on clinical leads for organ donation. And these specialist physicians are key to making the system work and helping change institutional cultures. So I'm really looking forward to hearing the speakers give us 10 minutes of their system and how it works there. And then we're going to have questions at the end of the 4 talks today. So without further ado, I'm going to introduce our first speaker, Dr. Andrew Healy, Chief Medical Officer of Donation at Trillium Gift of Life in Ontario, Canada. Thanks very much, Dr. Healy.
No problem. Thanks very much, David. Can you hear me okay?
Yeah, perfect.
Okay. So, yeah, just as David said, my name is Andrew. I'm the Chief Medical Officer, recently rechristened the Provincial Medical Director for Donation, and our program is undergoing a bit of transition now. So we're moving from an agency into an agency now known as Ontario Health. So I'll speak from the Ontario perspective, and I'll try and share a little bit of insight about the program of donation physicians across Canada. So I'm the provincial medical lead, and as you know, my colleague Sam Shemy is the national lead for national medical director for organ donation with Canadian Blood Services as the medical advisor there. Just to give you a very, very quick overview, in Canada, we have a number of organ donation organizations. Each province has one, aside from Alberta, which gets 2. And they will cover the territories as well in various portions. Each organ donation organization actually has a different structure for donation, the donation physician model. And in fact, everybody will manage things a little bit differently in each province. And then we have, as medical directors across the country, an advisory committee that then reports into Canadian Blood Services in an advisory relationship. So, recent big successes are an increase in the number of donation physicians in Saskatchewan, as well as in Nova Scotia with their recent legislation change. And even in Newfoundland, my home province, actually. So our system really began in 2013, and we can talk about academic papers, but in actual fact, it was the Toronto Star that really incited the Ontario government to invest in this program. Raphael Montesans visited Toronto in a flurry, influenced significantly at the provincial table. I've been known to be, very poor at asking for raises in my life, but the timing of Raphael's visit and then the call from the ministry was at the same time as when we were talking about how to engage physicians in the province. And at that time, Sunny Dhanani, which many of you will know, was in my seat as the Chief Medical Officer for Donation for the province. And so in 2013, we started with really a group of 6 physicians who were doing active call. We added 2 regional leads and then about 20 hospital donation physicians. And as you'll see, the program has grown quite significantly from there. Sunny was instrumental in that leadership over time, and we've now got a donation physician in each hospital that contributes to organ donation across the province of Ontario. So I'll give you a sense of the structure, and then I'm happy to take questions about where things are at the moment. So this is what the structure looks like. So the provincial medical director that currently sits with the senior director, Jan McLean, who are structurally supported by a physician program lead who is a nurse and is a full-time equivalent in the office. I'm compensated for about 8 days a month of protected time. And then under or with me, I have 6 very talented regional medical leads who look after about 10 hospitals each. in the various regions, some up to 12 hospitals, and they also focus on an area of specialization. So one of those regional medical leads is a palliative care physician, so does a lot of liaison with that community. Another is a neurologist and has been focused on that. Yet another is a neurointensivist, and so all of our regional medical leads and our medical director are ICU specialists, and most of our hospital donation physicians are in fact also intensivists, but not all. So Kelly, who's our physician program lead, really holds the program together. At this level, there are 2 directors that are responsible for 54 donation hospitals, 56 donation hospitals, depending on who you ask, in our province. And each of those hospitals has an embedded hospital donation physician. That really represents the sort of structure of ongoing asynchronous support for donation that exists in Ontario. Each hospital donation physician then has a paired, unremunerated, essentially, executive lead and operations lead at their hospital. The executive lead is usually at the senior leadership team table. The operations lead we try and have at the director of critical care for that hospital level, at least at the director level. And then those people are supported by organ and tissue donation coordinators in the very active hospitals, and in the smaller hospitals supported by hospital development coordinators who really function at a distance. The sort of blue signifies the structure that is compensated within Ontario Health or Trillium Gift of Life Network, and the green signifies what structures exist in the hospital. So those hospitals, through their committees and their activities, are supporting that. We jointly appoint the hospital donation physician, although that contractual renewal just happened. And the red roles are note 24/7 support. So our regional medical leads all do a 24/7 support call. I actually start in about 20 minutes. And so we are available by phone to support active donation cases, and we are paired with an employee at TGLN at OH, which does manager on-call duties. And so we partner to provide the logistical support sometimes and the medical support to active cases. And of course, our organ and tissue donation coordinators are dispatched to those hospitals actively on call. Our focus at TGLN for the physician program is really around every family and patient gets approached in organized and planned fashion in the ICU. And so we measure that using an eligible approach ratio. Our focus recently, just prior to the pandemic, was really elevating that for our expansive program in Ontario for medical assistance in dying. So we were one of the first jurisdictions in the world to note that we would ask people who are undergoing medical assistance in dying to if they wish to proceed with organ donation. So we have a clinical focus, and that focus is really around ensuring that ask is facilitated and that there are system structures in place for the support of organ donors within the hospital. And then there is a clear educational role for those hospital donation physicians across the province to focus on the ICU, the emergency department, or the operating room, and both education and support in donation and death determination. There are sort of structural supports. We have an integrated platform where the hospital and TGLN can see goal setting that the regional medical leads do with the hospital donation physicians twice a year. That process is just being now renewed post COVID or whatever, wherever we are in this pandemic. We have system audits like a recent audit that we did around structures for withdrawal of life-sustaining measures and their principal education that supports that. Our physician program lead and contractual reboot actually has served to refocus us a bit in this post-pandemic, intra-pandemic world that we're in at the moment. And I'll just say a brief word about partnerships. This was a study that was done by Amy Sartee and really facilitated through Sonny Dhanani in his time. The green and yellow nodes are regional and chief medical officers at that time, and the purple nodes are all hospital donation physicians. So we asked them who they call when they had questions. And so what we learned in this network is that actually the creation of the network was also quite powerful. We had some work to do beyond just the connection to the regional nodes, in that we're now trying to facilitate communication amongst hospital donation physicians. And you know, we got quickly invited to engage our two outstanding people that were a little farther outside of our network. So our current focus is really a reboot in education for HCPs and the ICU attendings and nursing staff. We have not been able to do very much of that through COVID. We actually did have a fellowship program where we accepted a fellow, two fellows actually, for a year. We are looking to think about that again, and we do have a number of hospitals that offer dedicated resident rotations, which allow us to support that. And then our real focus is around COVID recovery and building that new structure for a new way forward. So those metrics involve eligible approach rate, a look at integrated COVID recovery as the system pressures exist like they do everywhere, I think. We're clarifying those specialty roles that we spoke about earlier, and strengthening that HDP RML partnership. So that sort of gives you a flavor for what the system looks like in the province of Ontario in Canada. And I'd be happy to take some questions once we hear about the other models, David. So thanks very much for the opportunity to present today.
Thanks very much, Andrew, for excellent overview of the Canadian situation. And as Dale has said, you guys, in terms of how you go about building consensus and shifting the needle, is always very impressive. It's my pleasure now to introduce Helen Opdam. She's the National Medical Director of the Australian Organ and Tissue Donation and Transplantation Authority, an intensivist at heart, and she's going to talk to us. We're going from Canada to Australia now. Thanks very much, Helen.
Thanks, David. I just want to check that my slides are coming up okay. Does that present appropriately?
That's the presenter view. It's coming through to me in the presenter view, so I can get a sneak peek of the next slide.
All right, let me just try something a little different to that. Oh dear. Okay, just sorry.
No worries.
Normally I just have a, it's just because I've extended my screen. So
if you just click on it, Helen, I think then if we go to, we can change it when it starts.
All right, is that presenting?
Yeah, that's coming perfect.
Okay, perfect. Thanks so much. All right, so I'll just give a little bit of background of what's happened in Australia to provide a bit of context, and then to sort of emphasise how integral the role of medical donation specialists have been in the success of the national program. So we began our national program really in 2009, and it's been highly effective, increasing both rates of deceased organ donation and resulting transplant opportunities. I just want to describe how the world was a little bit before the reform. And in Australia, intensivists had, you know, really a lot of ownership of donation. They produced and still continue to produce a key statement around death determination in the context of organ donation, and also best practices in relation to organ donation. And really they had the key role of identifying donor opportunities. They undertook, you know, the donation request, as we used to refer to it then. And if it was only in the circumstance where family family agreed that there was then a referral to the external donation agency, and a donor coordinator would, attend the hospital and undertake a formal consent process with the family and begin the workup. And some audits, in fact, which I was involved in leading at the time, identified many missed opportunities for donation, particularly in the emergency department and the intensive care unit, mostly in patients with devastating brain injury who had treatment withdrawn prior to brain death developing, typically in the ED, older patients presenting with a large intracranial bleed, or in ICU, the typical patient was more medically complex, perhaps less clearly suitable for donation, so that the treating intensivist may have dismissed the opportunity, or with complex family dynamics where there was a decision that it wasn't appropriate to approach the family. And really, these were all patients with, donors at this point were donors with potential to donate after determination of brain death. There were few DCD donors and very few extended criteria donors. So with the national reform, the changes that occurred included the creation of a central organisation, a government organisation, the Organ and Tissue Authority, that really has a central coordinating function to bring stakeholders together and to employ key staff involved in donation. That includes my role as a national medical director, and also state medical directors for each of our 8 states and territories, and also dedicated donation staff within hospitals, which was new since 2009, and that included both nurses and fractionally employed doctors. And pre-existing agencies were brought under a Donate Life title, and those agencies and the newly employed hospital donation specialist staff formed the Donate Life Network. And it's really this Donate Life Network that's been the key means for driving change in donation practice. So this is the distribution of hospitals across the country that have dedicated staff. There are additional hospitals where we undertake a retrospective audit beyond these hospitals, and not all of these hospitals have medical donation specialists, really just the larger hospitals. And you can see from the FTE and the number of individuals employed in the roles that all of the medical donation specialist roles are really quite heavily fractionated. These individuals tend to be intensivists who have staff specialist roles in major public hospitals, and they do donation work usually 1 day or less a week. We do have a couple of emergency department physicians who are also in the medical donation specialist roles in hospitals. So the state medical directors really have a broad clinical leadership over the entire Donate Life network. They're really responsible for driving the embedding of best practices within hospitals, but also service delivery of the Donate Life agency. And they often, along with a select number of other individuals, also provide that on-call medical advice that Andrew was referring to as occurs in Canada. The hospital-based medical staff really act at a local level as clinical champions and provide leadership within the hospital. And together they lead the implementation of a range of best donation practices, which are articulated in a clinical practice improvement program. I'll come back to that. They really provide clinical advice, overcome barriers to donation, and engage with key stakeholders, including senior staff within the hospitals. They provide data, hospital performance metrics, and really smooth the way to ensuring donation, all the donation processes are undertaken optimally. And of course, participate in a range of educational events and regular meetings, which we undertake to get really all of those staff together, along with our donation nursing specialist staff. So what are some of the key things that the donation medical staff have really been instrumental in changing over the period of the national program? So again, earlier in the program, we had a lot of missed opportunities for donation. Earlier on, we introduced things like the Give Clinical Trigger, really mechanisms to help treating staff recognise potential organ donors. These were focused initially on patients with devastating brain injury and the potential for brain death, and were later broadened to a broader range of patients with donor potential. They were really most effective in the emergency department, and the blank squares on those graphics really enabled a tailored approach within the hospital, which was usually to refer the patient to the intensive care unit, where there could be either a plan to admit the patient to ICU for further time, and then family approach to explore donation if that was appropriate. Sometimes it meant raising donation in the emergency department. And the medical donation staff were really instrumental in overcoming medical, ethical and resource barriers that existed at the time that really had previously prevented patients in the emergency department with a poor prognosis being considered as potential donors. And these worked really well early in the reform, but as practice broadened, and particularly as DCD uptake increased and we had more medically marginal donors where determination of donor suitability was less clear, we found we needed really a broader donor identification strategy. So the State Medical Director and Agency Manager Group, which is our key strategic leading group nationally, agreed to introduce a process of routine referral notification to Donate Life. That could be the agency or embedded hospital staff for every patient in ICU and ED approaching end-of-life care at the point where there's medical consensus that the patient's likely to proceed to end-of-life, but prior to necessarily the family having reached that understanding, and particularly prior to any clear agreement with the family to proceed to withdrawal of cardiorespiratory support. And we embed this type of requirement or practice within a clinical practice improvement program, which is really our hospital plan that evolves over time. We're up to phase 4, and we have these key best practice requirements that need to be really embedded within the hospitals. Again, a lot of this is led and undertaken by the medical donation specialist staff, and then we report against adherence to these practices. So the reporting is undertaken by a retrospective audit of deaths, and when there's lack of adherence to these practices, again, the local medical donation specialist staff often follow up on a case-by-case basis, and they also share dashboard reports internally within the hospital. The other key area that medical donation staff have really been instrumental to changing practice in Australia is the approach to family communication. So again, this was very challenging. Again, historically, intensivists really had a lot of ownership and autonomy over this area of practice. The historical approach was very neutral. Sometimes families were not approached because it was not felt appropriate to do so. It was agreed that to change this practice would really require an evidence-based and inclusive approach, and the State Medical Director and Agency Manager Leadership Group in 2012 reviewed international practice, noting that really the highest consent rates with US research seem to be associated with a collaborative approach with a knowledgeable donation person along with the treating clinician approaching the family. It was agreed to trial this in Australia, to do it in a pilot way, and as a research project, this was really the only way we were going to get traction with the broader intensive care community. And this was undertaken and published with really the key way that we involved a person with specialist knowledge at that point was that we had someone who had undertaken a 2-day training program. And if we had that sort of clinician, whether it be, it was usually an intensive care specialist, it may have been a donor coordinator, in addition to the treating team, this was associated with the highest consent rates. And this practice has now evolved to require the presence of someone, who has done more than a 2-day workshop. We require really now donation specialist nurses to be involved along with the treating clinician in every family donation communication, and this continues to be associated with much higher consent rates. And our best practices are now articulated in a broad guideline, and they include various elements, routine referral at end of life to donation services, checking the registration status of a person prior to family approach, the involvement of a donation specialist, and again, driving this practice change and gaining acceptance amongst the intensive care community has relied upon our medical donation specialist staff. Some of the key tools to support all of this have involved our retrospective audit of deaths that is undertaken in all of our hospitals and really provides us with very granular data, as well as broader things like consent rates, but we can really dig down at a hospital level, case by case, and also really broader collated dashboard data. And again, our clinical practice improvement program, which really outlines the key requirements and what will be reported against at a national, regional and hospital level. And underpinning a lot of the change, particularly in family communication, has been a 2-day workshop. We developed it with the assistance of the Philadelphia Gift of Life Institute program. It was tailored to the Australian environment, first delivered in 2012, and importantly supported by our key medical societies, including our College of Intensive Care Medicine that deemed it mandatory training for all intensivists. And it's really helped us reframe the whole approach to donation in Australia, no longer requesting donation, really offering donation. And rather than donation as, something that was being done to families or, that we needed to at times protect families against, really about empowering families to make an informed choice about donation, ensuring they have the support and information they need, and really for donation to be truly embedded as a routine part of excellent end-of-life care. Thank you.
Thanks very much, Helen, on a very comprehensive overview of how Australia's gone about reforming a flat line and really making it take off. It's my pleasure to introduce Dale Gardner as the next speaker. He's the Associate Medical Director of Deceased Organ Donation in the NHS and the convener of this whole Tribute to Life project. But thanks very much, Dale. There, perfect.
Perfect. Thanks very much, David. It's my great pleasure to speak to you. We're just hearing some wonderful stories of the different ways we do it, but there's a lot of similarities and some small differences. So I'm now called the Associate Medical Director, but previously the title I had was National Clinical Lead for Organ Donation, which we call CLOD. And what our whole motivation of why we established CLODs in the UK was a simple matter of trying to take an intensive care doctor like myself, much younger in that picture, and giving that person a passion for donation, a heart for donation. And that's what we had to bring to intensive care. So if we go back in time, what we had a fundamental shift in the UK was that we realized that donation's not a transplant matter. It's an ICU end-of-life care matter. And we had to ask ourselves, who from intensive care will champion donation? And that was very much led by the first national CLOD, Dr. Paul Murphy, whose role I now have after his retirement, of really showing us this way. But just like you heard from Andrew, we were too inspired by Spain and Rafael Matanzas's words about intensive care, as this is by far the target group on which the efforts to improve organ donation must be concentrated. And that's the model we really sort of embraced in the UK. So we saw organ donation as part of just standard ICU end-of-life care. And that was our paradigm shift. We went from a concept The donation, as Helen had mentioned, something a bit strange, something potentially inflicted on families, to something actually, no, this is a fundamental component of good end-of-life care. And that came out of our task force recommendations in 2008. And so we built the building blocks, which are, of course, always about people. I think many, many times it's not about the documents. It's not about that. It's about the people and inspiring and allowing them to bring their creativity to roles. So we have three main people, and we call that the triumvirate within each hospital. We have a chair of an organ donation committee, we have a specialist nurse for organ donation, and we have our clinical lead for organ donation, whose role we're talking about today. So what does the clinical lead for organ donation do? Who are they? So 95% are from intensive care. The others are generally from emergency departments. So generally those acute specialties. And they're funded by the hospital, but they're reimbursed by NHS Blood and Transplant. So they still take their salary from the hospital, but their time is reimbursed by NHS Blood and Transplant. Majority are funded between 2 to 4 hours a week, depending on how busy their hospital is. So it's very much a management job. And what they do, what we do, is we provide clinical leadership and we champion improvements in our hospital. That's the main role. We don't attend every donor. We don't always get notified if there is a donor on our intensive care. Our job is much more in the background. So those responsibilities bear down to, we need to identify and contribute to resolving any local barriers to donation, to work very closely and support the specialist nurses who are assigned to that hospital, and to be a source of knowledge on that intensive care to the ethical and legal aspects of organ donation, and be ready to take a phone call and provide advice if needed. So there are 12 regions in the UK where it's divided up, and you can see that on the map. And the CLOD budget from NHS Blood and Transplant is around £2.5 million. There's approximately 240 CLODs across the country on that 2 to 4 hours per week. Then in each region, there is a regional CLOD structure for the 12 regions. And we have 18 regional CLODs across there. 17 are on 4 hours a week and one's on 8 hours a week. 6 of the regions have 2 regional CLODs for each region. And we're seeing a growing number of regional roles, education CLODs coming forward, which are proving valuable in the regions that have had that. Nationally, there's myself on 2.5 days a week. And then there's a number of other national roles. There's our quality CLOD on a day a week, innovation and research CLOD on a day a week, our medical education CLOD nationally on a day a week, and our pediatric CLOD on half a day a week. And we're ably supported by Jill Featherstone, who was a specialist nurse who works in the professional development service and leads on medical education, and she's full-time and supports Ben Ivory on the medical education CLOD role. So what do we do for our CLODs when they're appointed? Well, we reimburse any of their expenses they may have for education. We provide a 2-day aways CLOD induction in the first year. A lot of the education, though, happens at a regional level, and that's twice yearly, in the spring and in the autumn, each of the regions. Sometimes 2 regions will get together for a big event, but generally they're regional basis. And every 2 years, we have a national congress, which has been for the last number of years, is in partnership with the British Transplantation Society, working with us in NHS Blood and Transplant. So what do they do on a weekly basis? These are some of the activities we have. And we actually have an annual one-to-one with the regional CLOD. Every local CLOD has an annual one-to-one with the regional CLODs. And I have an annual one-to-one with the regional and national CLODs. So there's an expectation for the local CLOD that they meet with a specialist nurse, at least on a monthly basis, that they attend the organ donation committee within their hospital. They have that annual one-to-one, they attend the regional collaboratives, and they actually review the potential donor audit data and in the hospital, and they present that to the board, and they keep their policies up to date. When all that's added up, it's approximately 2 hours per week, which is what we see as the minimum CLOD payment. Of course, that's just the bare minimum of what we expect, and especially if people are doing more. But when we think in terms of 2 broad themes, I'd say that the actual key is to act on any missed donation opportunities with the SNOD, to look at the potential donor audit, looking for missed opportunities. The hardest bit of the job, challenging colleagues and local barriers, but that's many ways what the whole system is is built around taking a senior clinician and putting them in this role with a passion for and a champion of organ donation, and coming up with a local action plan, because it's not always easy, but you need plans for that. And as I said earlier, providing that local clinical expertise. So what have we achieved then over time? I point to sort of two big graphs. One is our referral rate of any potential organ donor. When we began this process, you can see that for donation after brain death, it was 83% referral, and for donation after circulatory death, down at 36%. We have over the years built that with increasing improvements. And just like Helen highlighted with the specialist nurse presence, that's been a high priority for us. And we can see that since we really put an emphasis on that collaborative approach in 2011, we took the fact of specialist nurses being there when donations discussed with the family from 63% all the way up to 92%, because our own evidence, similar to what Helen shared, is the odds ratio if the specialist nurse is not present, so she's not present, is terrible. If you had anything else in intensive care with odds ratios like that, it'd be absolutely what you'd expect that we would implement if it was a new drug or a new treatment. Well, this intervention has a massive benefit for families, not only I think in the consent rate, but also in actually the care they can provide, which is always our emphasis. And really just sort of to finish up, the CLOD role is an exciting role, and people really enjoy it. And often I've heard many times people say it's actually one of the best bits of their job. And I think that's because when they take the job, they have an inbuilt network of ICU colleagues, not only in their region, but also across the country. Makes you feel like you're part of something bigger than yourself. There's huge opportunities for professional development with education, management, research, and innovation. We don't micromanage our CLODs very much. There's a large degree of freedom in terms of day-to-day work and what's expected, as long as those sort of, trying to look at missed opportunities, trying to make things better. That's all we really ask. And of course, we give lots of pink freebies with our pink's our organ donation color. So with our badges and our pens and our shirts, even if you want to wear them in public. Thanks very much.
Thanks very much, Dale. It's now my pleasure to introduce our last speaker, Waqas Akhtar, who has got a new acronym that I wasn't aware of before I saw these webinars of TROD, and he's going to tell us about that and how appropriate the acronym is. Thanks very much.
Thanks, David. Can you see my screen?
Yeah, it's come up perfectly.
Perfect. Yeah. Thank you very much for this opportunity to speak. I'm going to be talking about TRODS. We love a good acronym, and this one stands for Trainee Representative in Organ Donation, so mimicking the CLOD role. My name is Waqas. I'm the London Regional TROD. I'm also the Chief Registrar, specialising in transplant cardiology and intensive care at the Royal Brompton and Harefield Hospital in London. I'm just going to cover a bit about who TRODs are, what the TROD involves, some of the team projects that have been carried out, and particularly a bit about my project on Heart Transplant Champions. So the trainee representative in organ donation is typically a senior registrar, so from adult and pediatric intensive care or emergency medicine. So that's typically someone who spent 6 or 7 years post-medical school as a doctor. It's a voluntary unpaid role, and the typical expectation is a 1 to 2 days commitment per month, which can be taken out from study leave, which is part of all trainees' allowance. These are the current TRODs in the UK, so separated also by region. And the role of trainee representative in organ donation is multifaceted. So one is to support the development of organ donation practice in the region. So that's working with the local and regional teams and CLODs and SNOTs. And also to act as advocates for organ donation amongst the peers of trainees. The second is to support educational initiatives and share learning across regions, and the Deceased Organ Donation course is an excellent example of courses that TRODs have attended and also help out on the faculty of. Thirdly, they also act as a voice for trainees in local and regional organ donation committees, and this helps trainees to develop organizational and leadership skills, potentially future being involved as donation physicians. And Fourthly, there are a number of quality improvement projects that the TROD roles, even being relatively new, have been participating in. And they fall into various themes. So there's an educational theme, such as the donation SIM course, developing modules for our specialist nurses in organ donation, and podcasts for trainees. Some have participated in research, so becoming an associate principal investigator, and one trial recently is the SIGNET trial, which is statin use in donors. Others have been involved in management aspects, such as being an organizing team for the National Congress, and others have been involved predominantly in networking, so developing relationships with local coroners and acting as advocates amongst the trainee group. I'm just going to talk briefly about my project, which I've been working on, which is the Heart Transplant Champions. The issue we had, which is sure is similar elsewhere in the world, is an insufficient number of heart donors in the UK, the line showing the numbers on the waiting list and the bar showing the number of transplants carried out. And we looked to assess the availability and quality of echo imaging for donors as a potential cause for insufficient numbers of heart donors. These were audits within our unit, just prospectively looking at echo availability, and up to 70% of cases had no images available for review by the transplant centre, and asking the transplant surgeons whether this might have changed the decision. In a third of cases, reviewing the history this potentially could have done. We also reviewed all the retrievals that were carried out in the UK over this time period, and we found a third of these cases declined on repeat echo assessment and review. And this either indicated that the heart had changed during that process, which could have happened, or that the initial echo was perhaps not as accurate as the subsequent scan. We also looked within London to who was performing these scans, and we found that actually the majority of scans were being performed by trainee doctors who have varying levels of accreditation. Sonographers in the UK predominantly all hold full level 2 accreditation, but many doctors are now gaining level 1 accreditation, which is an intermediate echo accreditation. And that's what we looked to see if we could try and utilize. And we said the minimum standard, we wanted everyone to have an echo, but then also if it was a level 1 scanner, to have the images reviewed by a transplant center. And to this extent, we developed the Heart Transplant Champions program. The program involved liaising between the transplant and donor hospitals to understand the processes where there were barriers to echocardiography with the intensive care teams and SNOD teams. We developed a volunteer network through Teams. The Microsoft Teams is universally available in the NHS. So we used this as a method of communicating between the transplant and donor hospital if there was difficulty getting echoes, to find a volunteer who may be able to help. And we also used this same network to review the imaging, which is either using the echo software or live via camera, so that the burden of interpretation wasn't placed on the donor hospital. And this is particularly relevant out of hours, where if it was to be a DCD donation, the time is tight. So this is how it would normally work, is the IC team would refer to the SNODs. The SNODs, the nurses ordination would request the echo. If there's any difficulty, the champions will be contacted. We'd review it virtually, and a retrieval team would be dispatched, and the TOE would be available if needed. This is practically what it looks like on Teams, having our donor hospitals in the same forum with all the transplant team and the specialist nurses in organ donation. Ideally, this would be a paid service, but we're trying to establish some evidence base, so it's voluntary at the moment, but we offer certification and an educational program for the donor hospitals. We're predominantly just trialing this in London. Hayfield is the transplant centre for Heart Transplant Centre for London, and we're predominantly trialing it in the Northwest London area, but we're hoping to expand it. And this is some of the communication we send. And we're also developing a minimum echo data set to aid donor hospitals in the images that ideally would be acquired for assessment of the heart that can be subsequently reviewed. For this project, we're hoping to carry out a national audit, approach chairs for organ donation committees for funding, we're ramping up recruitment, and we're developing this echo minimum data set. So I hope I give you an overview of the TROD roles and some of the benefits. This is the current TROD team in the UK. And I thank you for listening, and I'm happy to take any questions.
Thank you very, very much. I think the quality of your slide set shows that we need to invest in the youth. It's very impressive, and your ideas and following through are really great. Please, anyone on the attendees list, please do type in your questions if you want me to ask them to the panelists. I'm actually going to open with the first question that I saw. Dan Harvey, who I noticed came out from one of Dale's slides in terms of his research role for the CLODs. And he's asked a question of Helen. Why do you think the Australian ICUs are motivated by research interventions so well?
Thanks for the question, Dan. I suspect it's the same everywhere. I think critical care physicians, look to the evidence, and if you say we want to change something, they say, well, what's the evidence? We don't think that's particularly going to be better. So in order to have a significant practice change, and this was to really introduce nurse donation specialists or people with specific donation expertise and training into that family communication, the idea of doing it as a research study really enabled us to introduce that practice and for people to become familiar with it. And look, ultimately, it was a positive study, but even if it wasn't, I think it would not have meant we didn't still embark upon that practice because I think people could see it provided better informed decision-making for families. For memory, I think the UK did a similar study which did not necessarily show a difference, but it didn't stop SNODs developing a lead role in family communication. So I just think it's a good way to introduce change and gets a lot more traction with people who, are critical thinkers and want some evidence.
Cool. Dan, your hand's up. Do you want to just expand on your role and research in general?
Oh, thank you, Helen. I completely agree, and you're right. Critical care, whole teams are often motivated by not just best evidence, but a desire to try and develop the best evidence if it isn't there. I guess from a UK context, we've often been quite good, I think, at making changes, and actually we're quite good at sort of auditing and measuring what the impact of those changes are, but we've been much less good at trying to explain the reasons why. And that's particularly important if, as you say, if something doesn't work the way you might have expected to, probably more important than if it does, because then we know where to put our next interventions and which bits of our experience and everywhere else in the world might be exportable to other countries. And it's difficult if you haven't answered all of those questions. And that's where my role comes in. So an attempt by us to try and integrate research into quality improvement and change from the outset, bedeviled as always by the problems of funding, and as soon as we add research to any intervention, that, as you know, quite rightly, but the sort of administration and regulation of that goes up tenfold, and it can actually make the change harder, and that there's a balance there. But I think we've been very much inspired by colleagues in Australia and in Canada and in other places who have been much better at integrating this right from the start, I think.
Thanks, Dan. I've got a question for Andrew myself. We have quite siloed ICUs, and I saw that you have your hospital leads. For me, it would almost need to be on an individual ICU basis, because we have neurosurgeons in charge of their own ICU. And those silos are quite difficult to break down. How do you approach that?
So I think in many of our smaller hospitals, there's one ICU that sort of reports in through that hospital donation physician. But they're in some of the larger hospitals for sure. We do struggle a little bit, particularly actually interesting that Waqas is on the line, but particularly in some of our CV ICUs, I think the potential there tends to be lower, and our representatives in those bigger ICUs tend to be they do tend to be from the neurosurgical side or the medical surgical side. So it isn't by any stretch of the imagination perfect, but in the larger centers, I think the way in which the ICU group in the hospital, as well as the Ontario Health Group, selects those candidates, we're careful to ensure that they're people that generally build consensus. So we haven't struggled with that in a large part outside of one or two centers where the challenges are particular to that group.
Okay. And do you route your phone calls through a single number with a call center operator? We have quite a fragmented system. And does the person, when they phone, get straight through to the doctor, or how do you screen it or put a system in place for that?
So we have routine notification and referral in Ontario and in most provinces now, I think in Canada. So we have a 24/7 call center that then actually the physicians really provide a supportive role. They are not, the hospital donation physicians are not really a function of the ongoing case-to-case activity unless there's a real challenge. So our equivalent for the specialist nurse in donation role, which is the organ and tissue donation coordinators, whose name are undoubtedly going to change, like everybody, in the next few weeks or months. But you know, those are the people that coordinate the activity, much like in the UK, I think. Although ours are employed directly through TGLN and then can be dispatched to various hospitals, so they don't necessarily only function within that hospital. So an ICU professional would, you know, whether that's a nurse or a physician, would notify us in a similar way to what you've heard today. That call center would manage the case initially by phone, and subsequently, once we're ready to approach for consent, dispatch somebody in person. And then the specialist nurse or the organ and tissue donation coordinator would then connect with the donation support physician as needed. And then those physicians will often use the hospital donation physician if there's active challenges within that particular hospital that need to be sorted out, and you know, a difficult echocardiogram or difficult diagnostic imaging or however that active case was. And like others have said, the active case follow-up is also a key part of our, you know, this didn't go well or this went well. Can we find ways to build the team in that way? So
thank you. Dale, you've helped implement the TROD system in the UK. Do you want to comment on how it's going from your point of view?
Yeah, thanks, David. Yeah, I mean, you just saw Wakas's amazing talk and things. It's just interesting, you know, as someone who sort of started to establish that, I'm both torn by how good it's been, but also how, when I look at the Canadian work of the evidence base and how we're not doing that, sometimes in the UK, we're just guilty of just doing it. And so when we began this idea and sort of came out of pediatrics and some of the local areas of having these trainee representatives, I thought this is great. We just need to do it. And there was some chat about getting it formally approved and looking to get it paid. And I could just see that would take 10 or 15 years and still not be there. And so we just did it. And we thought, well, let's see if anyone volunteers to come. And really, we were totally overwhelmed by the enthusiasm and the bringing of the skills. And it very much reminds me of a lecture I heard about the advice to us from an older generation with the newer generation is when they come to you with a good idea, probably just say yes if you can, because ultimately you'll probably be doing whatever they're saying in the next 10 years. And I think that's wise advice. And for when people have come up with great ideas from the next generation, because they will inherit what we have built and they will take it even further. So it's been absolutely overwhelming. Some of my colleagues were a bit sort of wondering how good it would be, but when they actually met the TRODs from other regions, they went, we need this, because they bring such energy and enthusiasm. So there you go. It cost us nothing. We unfortunately are not researching it and to show the great benefit, which we probably should, and we should be publishing it. But actually, I think it's going to be a game changer for us. These are the clods of the future. These are my people who will take my role in the future because they come with such enthusiasm, energy, and ideas. So thank you, Wakas and colleagues, for being our first group of TRODs for 2022, because it's the first year we've done it.
I must admit the evidence base really does help. I mean, I've been asked to do a needs analysis that we need a single phone number to call through. It's just such an intuitive thing that it just needs to be done, but people actually do question this. It's important work, and I think using this network to leverage those type of resources is something that I hope all the listeners to these talks realize is available and do reach out, because this work done on on ethics manuals for donation, that those are fully transferable across jurisdictions. And you need to have a look at it and see what you can apply locally. I had a question for Helen. You've done good reforms in Australia. We're not quite as provincial or divided into states as Australia and Canada seem to be. How did you approach the reform? Because there's mechanisms there to go a legislative route, a regulation route, or on an individual sort of hospital SOP route. How did you allocate it and allocate the implementation of those standards?
Look, that's a tricky question. I think we're similar to Canada, as you've pointed out, having sort of like a federated system. We have a lot of challenges with, you know, a national government and then state or provincial type governments. And one of the biggest difficulties is sort of privacy legislation and being able to sort of use data that we actually pay for and collect nationally, because it's sort of considered to be state owned. And so look, a lot of the barriers have really been, you know, having committees where we have health bureaucrats from each of the states, the state medical directors, and then people nationally within OTA meet regularly so that we can make forward progress. The reform got legs because it was new national, you know, new federal money, and that money is funneled through the Organ and Tissue Authority to each state government with a very detailed agreement as to what it's to be used for, and that is for particularly the employment of the hospital donation specialist staff that I've described. But we meet regularly with the state medical directors and the managers who oversee those staff. We have committees and forums, and we can really, through those committees, implement the agreed change, which really all comes from the lead clinicians. One of the barriers we had early on was, you know, the Organ and Tissue Authority sounded a bit authoritarian, and there was a bit of a concern in the sector that, you know, government was sort of going to be telling clinicians what to do. But it's a really a heavily clinician-led program. I'm sort of interested because countries here have been selected that all have donation physicians. You know, the US, we don't have anyone from the US. Is really a standout where it's, you know, very different system. There's not the same role, it seems, of intensivists in donation. And sometimes, you know, we've looked at sort of the resource put into supporting intensivists in donation roles, and I wonder what would happen if we didn't have them. I personally feel we wouldn't have the advances that we have in the system. I wonder if our co-panelists feel the same. How important is it having doctors and not leaving the whole thing up to organ procurement organisations and donor coordinators?
Dale, do you want to answer that?
Yeah, that's a great question. The metaphor, the analogy I often use is that the clods, our clods or donation physicians, are the oil in the machine. And what I mean by that is, we've got to drive forward. You need petrol to power it. And I think our specialist nurses have very much done that, as in they're the energy with that. But a machine with no oil just grinds to a halt. And relationships just grind and don't go anywhere, and actually things explode without great oil in machines. And that's really what the clod role or donation physician is. And that's why it's a management role. And 2 to 4 hours a week is probably okay, because we're not actually in this role, not asking them to be there for every donor, but we're asking them to sort of think behind the scenes and to smooth the way and allow the energy of the donation nurses to carry things forward.
No, cool. Thanks very much, Dale. If there's no further questions for anyone, I think we've reached the hour mark. So it's my pleasure to bring this meeting to a close. I hope I've learned a lot. I hope everyone else had, and congratulations to the speakers on excellent talks and ideas. And it's all about cross-pollination, because we're all trying to do the same thing, and we can help each other out with the different aspects. Thank you very much, everyone. Helen, Dale, Andrew, Wakas, thank you so much.
Thanks, everyone. All the best.
Pleasure.